I'm super excited to introduce you to Dr. Ilana Cass, who's our visiting professor, our keynote speaker. I met Dr. Cass mostly giving boards in Dallas, giving boards that, the boards that nobody wants to take, but everybody benefits from in the end. So I got to know her there. We also serve on the board of the Council of University Chairs in OBGYN because she's the chair at Dartmouth. Okay, so just a little bit of background about Ilana. Her CV is so long, it would take the whole hour, but she is a very prominent GYN oncologist, a national leader. She started her upbringing in St. Paul, Minnesota, so this is a bit of a homecoming. So she's actually from Minnesota, but went to Brown for college, then went to medical school at Mount Sinai, and then she went to she went to residency. I got it. I'm good. I'm there. She went to residency at Yale, and then she went back to New York for her GYN oncology fellowship at Albert Einstein. And after that, she went to Cedars in LA. So she's been around the country. She climbed the ranks at Cedars and did amazing work there. She has over 100 publications, multiple grants. As I said, she's a prominent leader, a national leader in the field of GYN oncology. She has a lot of research focus areas. One of them is hereditary cancers. Today, she's going to talk about HPV because it's a passion project for her. So I could go on and on about Dr. Cass. She's done a lot of amazing things through the Society of GYN Oncologists, but I'm going to stop there and let you all get to know her. And I want everybody to give her a very, very warm Wisconsin welcome. So thank you, Dr. Cass.
All right. Can you hear me? Good. Fantastic. So I have left Beverly Hills and Hollywood, but I still like to parade around a little bit. So I'm going to continue to do that. So thank you very much for allowing me to speak on exactly as Ellen has described. Full disclosure, I have done no original research in the realm thus far on HPV, although I will tell you about what we're looking at Dartmouth in this space. But this began literally my journey with the HPV vaccine, and sort of the passion project began, like it may have for many of you, with the data in 2006 about this promising vaccine. For a very real moment in time, I, perhaps delusional as a young GYN oncologist, really thought we would never take care of patients with cervical cancer again. I thought this was it, this would be over. And finally, for me, this was really forged in the crucible of arguments that I had repeatedly with my children's mothers, mostly on the playground, about, should I get this HPV vaccine? What do you think, Ilana? And therein began my sort of love affair with how have we basically seen the promise and reality of HPV vaccination. So let me move on. Okay, the objectives of the talk, there you go. But here's the meat, right? So if you have a sip of coffee, look at this slide, and then fade away and fall asleep for the remainder of my time together, that's fine with me. But the take-home points that I really want to emphasize through the course of this lecture, now informed and bolstered by data, really are that reducing cervical cancer, right, through HPV vaccination takes time. And we need to explain this to people by virtue of the natural history of human papillomavirus infection, and then the resulting progression through dysplasia and onto cancer. Therefore, we don't see the results right away, okay? Number two, we vaccinate despite a prior history of HPV infection or abnormal pap smear. And this is a point that I think, again, we just, as advocates for women, we have to lean into this point so hard as we educate our patients, their families, and our own colleagues about the importance of HPV vaccination. And I will spend a little bit of time, I think, at this very important inflection point in time in medicine. How do we manage the message as ambassadors of science to help our patients with regards to the backdrop of the political landscape that we can no longer ignore, we live in? And then finally, some really exciting new news about vaccination and potential to reduce HPV-related risk recurrence and some of the sort of prospective trial that is just about to embark. So HPV infection, the life cycle you are all very well familiar with. I think the key points here to really emphasize are that while there are more than 100 types of HPV subtypes that have been described, there are about 15 that really make it onto the most wanted list or the high-risk HPV subtypes. And we understand when it comes to sort of the natural progression or natural history of HPV infection, right? That the majority of people who get infected, 90% of those cases will heal, resolve, and there will be no sequelae for that particular individual. A very small percentage of patients over decades, and this is the important part, over decades will actually have persistent infection, which can then go on in some individuals to cause cervical dysplasia or cervical cancer. And I'm going to move on to this slide just in the interest of time. This is really allowing us to kind of take a closer look at the fate or the sort of what is the landscape of HPV infection in general in women. And we know that about 75% of the population, and this would be a largely sexually active population. I used to tell my patients when I was at Cedars, like if we could take an imaginary field trip to the mall across the street because we want coffee, and I had a magic wand that I could just run over people as we walked by, pretty much anyone under the age of 60, we're going to find that wand is going to signal that this is a person that's been exposed to HPV about 75% of the time. But you can see, again, the actual breakdown. It is the minority of people who will have genital warts, about 1%. 4% will have some kind of abnormal pap smear. And then you can see about 10% of patients, of women who've been exposed, will have evidence of HPV DNA in the genital tract. But the majority of people will have antibodies and absolutely no presence of HPV DNA in the lower genital tract. And then about 25% of the population has not been exposed. This construct, you will see these kind of numbers again when we look at some of the data about the early Merck trials, specifically for the quadrivalent, and who entered into that trial. So recognizing that this is sort of a snapshot in time of the sexually active or population inclusive of sexually active individuals, we can see the really far reach of HPV infection. And this is some of the most recent data that I can find that, again, just reinforces this notion of the prevalence of HPV infection. This is nice because it includes men and women. This is through 2013-14 and was reported in 2019. And you can see, in general, when you look at different age brackets, about 1/3 of women, all in, have been exposed to have HPV infection, and about 45% of men. And recognizing that this can change over time, this was just some of the largest mature data that I could find to share with you all. So we would be wrong of us to focus just on the United States of America and not pause for a moment and consider the impact of HPV infection and specifically HPV-related cancers in the world. For any of you who have done, mission work or work where you've gone to sort of under-resourced countries, it's devastating when you actually consider the magnitude, the weight of cervical cancer that falls upon women in the world. So all in, about 5% of cancers in the world are related to HPV. 625,000 cancers in women, about a tenth of that, about 70,000 in men. But what's really important, I think, as we project forward about this technology, is 90% of the deaths related to cervical cancer occur in lower resourced countries. And this is places where, again, access to a GYN oncologist, access to good, safe radiation oncology, these are just things that don't exist. So this is really where we have to learn and sort of sharpen our message and also impact so that we can really help, our sisters around the world, because this is epic. We've made significant progress with access to screening, obviously, in the United States of America, but these are just things that are not as plentiful as they should be. So I like this slide because it combines men and women, and a couple of important trends that I want you all to notice here. With regards to the number of cancers in the United States of America attributable to HPV infection, what is immediately apparent is it's cancers in men and women. And you can see at the very tippy top, vaginal cancer, followed by penile cancer, and then on down. But I think what's important to recognize is that all in the US, that's about 45,000 cancer diagnoses per year. And what's also immediately apparent is look at the, woo, it's not working, that doesn't matter. Okay, so winner, winner, chicken dinner, oropharyngeal cancer at the bottom. Actually, the number of oropharyngeal cancers attributable to HPV infection now exceeds cervical cancer. Many of us have seen prior versions of this slide in which that bottom plank was cervical cancer, right? But no more. So this is the sort of newer landscape that we can see. And also interesting and important to remember, oropharyngeal cancer, much more prevalent in men, HPV related and all in, than women. Okay, so that's interesting, and we will revisit that concept. But what does this look like when you consider the actual, so the magnitude of cancers? This is a slide that shows you what percentage of all cancers that have that are driven by HPV, what percentage of those cancers are actually HPV positive. Again, really important for us as we craft and think about a message around the potential benefits of HPV vaccination when we can basically join forces with other individuals in the cancer community and say, look at the impact this could have in the United States of America for our population. So cervical cancer, obviously at the top of the list, but again, not trivial, the number of cancers here that are driven by HPV. So clearly a very far-reaching impact with effective vaccination strategies. So in that background, then we move to the vaccine. And I know all of you guys have been in the same situation, whether it's on the schoolyard or whether it's with your colleagues or your patients, explaining that the HPV vaccine is an empty viral capsid. It does not cause HPV infection. We've all become obviously very facile now in explaining vaccines and become sort of junior virologists, but it elicits an immune response in the host, and that response is quite robust after immediate vaccination. So this is how the vaccine works. And I'm sharing with you, I'm dating myself because this is really, really old data from the original HPV-16 only vaccine that was used. But I like this slide, and I've updated this for you all with some of the data from Merck, who obviously makes Gardasil. What we see that I'm trying to bring to your attention and highlight is after 3, because once upon a time for youngsters, it was 3 shots. This was the HPV-16 vaccine depicted by those little pink triangles. You can see this incredibly huge spike in the antibody that is generated. I will remind you guys that the y-axis is a logarithmic scale. Okay, so consider that when you're thinking about the antibody that's generated, exceedingly robust. And this hashed line that I've depicted in green is, as best we can figure, what is the HPV antibody in serum that results from natural infection. And as I'd indicated to you, we've already sort of explained that a lot of the population has been exposed to HPV. And the truth is, we do not know sort of what's the magic threshold of antibody that protects an individual from, say, getting infected or getting infected with a different viral subtype. But I want to emphasize that the difference between natural infection, this data only goes out to 4 years, but now as we have prospective data that has followed the nonavalent vaccine for 9-10 years, and some of the bivalent vaccine for actually up to 15 years, we see that there is this sort of retained, exceedingly high antibody titer that is 2 log folds higher than that which we see with natural infection for the ongoing duration of follow-up in these women. So 10 and 15 years later, in other words, we are still seeing exceedingly robust antibody response. What we don't know, again, and this is the question I always get asked, will my child ever need a booster for HPV vaccine? We don't know. But at this point in time, based upon the data that we have, we're very confident that we do have a preserved or ongoing, very robust antibody titer, which seems to be protective. And how do we know it's protective? I'll show you some of that data. The proof is in the pudding, right? Vaccinated individuals remain protected years after vaccination. So again, just wanted to share some of that data with you with regards to what do we know now in 2024, recognizing some of the early data that came out that led to the HPV vaccine when it was first released. So the current sort of high-level comparison here of HPV subtypes. Again, once upon a time, there was the bivalent, then there was the quadrivalent, now the nonavalent. The only vaccine available in the United States of America now is the nonavalent. That's a Merck product, I have to say that. And we know that HPV 6 and 11 are largely causes of warts. We know that 16 and 18 cause collectively about 70% of cervical cancer. And we can see that some of the remaining high-risk viral subtypes contribute an additional 15% of cervical cancer. So all in, this is sort of the rationale for the nonavalent, okay? And so the timeline, let's pause and take this in, because when I reflect on the fact that this has happened in my lifetime, it's actually pretty awesome. Now, of course, with COVID, one could also argue that was pretty awesome, right? How quickly we had that vaccine up and running. But when, again, we consider 2006, the quadrivalent was actually approved for girls ages 9 to 26 to prevent cervical cancer. The bivalent then came along, and we were very confident that that would drive the cost down, and perhaps a little friendly competition between the two drug companies would spur more vaccination. You can then see expanded indications. This is typically issued by the FDA when they feel there is compelling data to suggest that the vaccine in question may have a salutary effect on decreasing certain cancers. They issue what's called an expanded indication. That is different from an actual approval. Again, we've all become very well versed in this as we've watched the COVID vaccine journey. But I want to point out to folks, you can see vulvar cancer, vaginal cancer, anal cancer, and then 2011, boys. Boys are now vaccinated, right? Now, my poor son did not know this timeline because he was vaccinated right out of the starting gate. And when he was asked, why am I the only boy who's getting this? I said, because you're protecting the women that you love in your life, my dear. So he will now feel like he's now in the cool crowd because boys are vaccinated more and more. But you can see 2014, the nonavalent was approved. Then we moved to 2 shots of the Gardasil, which was super. Again, my kids all got 3 shots. They still are mad about that, but that was in November 16. And then you can see in 2018, based upon the Future 3 trial, the age was expanded now, and women up to the ages of 45. I'm sorry, men and women up to the age of 45. 3 shots for individuals over the age of 15, I need to point out, based upon the reduction in the cancers listed above. And then in 2020, another expanded indication, and this time to prevent oropharyngeal cancer, right? So interesting how we see this kind of play itself over time. So with that timeline that we've spent a little bit on, let me take you back. Oh, sorry. Before we do, I must digress. So let's talk about sexual activity in teenagers, okay? And this is the slide that always makes people, depending upon the audience, squirm. I can hear it as I give this talk. Usually I get more squirming with pediatricians than I do with gynecologists. But the reality is, and this is so incredibly important, about us understanding our role in being ambassadors for HPV vaccination. And it's important about us understanding the realities of sexual activity in our youngsters, right? Because the truth is, the slide here, which I have not refreshed, but I have to believe has remained the same over time, is that approximately when you look at 9th graders, that's about 15 years of age, 1/3 of those youngsters have engaged in vaginal penetrative intercourse. Okay, the women have, the girls. And by the time you hit an individual who is 17, sort of 11th or 12th grade, 17, 18, we're now talking about well over half of these youngsters have engaged in vaginal penetrative intercourse. And so what we understand, building upon the fundamental tenets of vaccination, is that if we can vaccinate youngsters before sexual activity, we know there is more protection, number one. Number two, from ample data in the sort of vaccine world and amongst pediatricians. We also know that earlier vaccination results in a more robust and more sustained antibody response. So it's better protection when our youngsters need it that covers them for a longer portion of their life. And we cannot be passionate about, we cannot recognize the importance of the message, when do we have to vaccinate our little ones, unless we take a hard, cold look in the mirror and we understand our kids are sexually active, whether we know it or think they are or not. And we must do everything we can to protect them, recognizing the realities of being a teenager. So this is just my little, again, make everybody uncomfortable, because this is who we are. This is who we are, and we have to own it, and we have to actually help protect our little ones, so that we profit from science just like the rest of us. So the final point to make about why we should vaccinate individuals agnostic to a prior abnormal pap smear or HPV infection is this data. Now, admittedly, we're looking at one of the Gardasil entry population, a population that was screened for a number of sexual partners, and they intentionally tried to enrich their population with individuals who did not have HPV, because of course they wanted to see what would be the impact of HPV vaccination. So they wanted to have more of the population be HPV naive. But in this population of thousands of patients, 73% were naive to all 4 HPV vaccine subtypes, okay? And one of the exclusion criteria that you can see there at the very bottom is if you'd had 6 or more sexual partners, you were not eligible to participate in the original HPV vaccine trials, okay? But what they did see amongst the remaining 27% of people who had been exposed to HPV is that 20% of them were positive to one type, okay? 6% of them were positive, and that's depicted in the gray, to 2 types. This is the quadrivalent vaccine. And 0.1% of individuals in that trial had actually had the misfortune in their sexual journeys of being exposed to all 4 viral subtypes that were contained within the quadrivalent. That means that almost everybody, even if they had been exposed to HPV, was going to derive some benefit from the quadrivalent by virtue of the fact that it contained 4 subtypes. The updated data for the nonavalent, I will leave the math to you, but suffice to say, for individuals certainly up to the age of 26, and now with the FDA expansion up to 45, you can make a very compelling argument that there is benefit to be gained using your clinical judgment for individuals and sort of shared decision-making, even if they have a history of an abnormal pap smear, even if they have a history of HPV infection, okay? So really, really important point that I think, again, we have to be ambassadors for science to really help protect women. So let me take you back in time. We thought, that looks like a pretty compelling ad, right? Pretty good marketing, sounds good to me. Let me take you back in time. Let me take you back. Oh, sorry, I keep doing that. This was the argument that I made to my son. All right, and that I make to audiences everywhere. Why vaccinate boys? And again, this is in the days before the uptick in oropharyngeal cancer. So the compelling arguments were, women will be more protected if men are protected, right? That's certainly our world and what we see. We can protect men from venereal warts, which is a thing in men. There are also, we know, certain cancers, including oropharyngeal cancer at the time, although it was not a big player, that we know will be reduced in number if we use HPV vaccination. So armed with that lovely sort of advert that you saw, armed with this information from the trials and the population that derived benefit, we thought, from HPV vaccination, with not a shred of data yet to show that we actually reduced any HPV-related disease, off we went as ambassadors of this magnificent moment in time and science to educate the world and America about, come on, let's get on board with vaccination. So let me take you back in time to 2007, okay? And in 2007, we've seen so many bloody maps, and I'm really sorry to show you still yet another map, but bear with me for 2 slides, okay? So what we see and this is what things look like in 2007, high hopes, right? We thought this is awesome. I will never have to, abort a radical hysterectomy on a patient because she's got positive nodes and have to go out, take that long march and talk to the family about, I'm really sorry, right? I will not have to have, a patient come in through the ER with a huge fungating mass and she's got a hemoglobin of 4 and her kidneys are, boxed and that's gonna go away. That's what we thought, right? And we saw pretty quickly, right? 22 states introduced legislation about the importance of HPV vaccination. Schools had mandates, you can see in the blue, that they were going to mandate HPV vaccination before kids could matriculate in school, all right? A school mandate was successfully passed in Virginia, but you can see, I think, just a cursory look at this map, lots of blue, okay? And blue meant that state legislatures and school districts were getting on board with adopting HPV vaccination as something that was going to change the fate of our youth, right? You can see the red states, a school mandate was defeated or withdrawn. And we have to include, again, taking you back to a small moment in time, the journey of Texas, which was fascinating for those of us that were watching it at the time, as Governor Perry leaned into an executive order, actually used their authority to make an executive order about the importance of HPV vaccine. And then that was promptly, that was tossed out by the state, okay? So with that 2007 picture, let's go fast forward now to where we stand today. Okay, so this is a map as of 2019, prior to COVID. And what you can see here, I've tried to depict is the number of the eligible population of youngsters who have received HPV vaccination. We talked about this at dinner last night, and Wisconsin is doing very, very well there, between 54 and 64%, so props to you guys. As are we, happily enough, in New Hampshire. But what you can see here is that 25 states passed some laws requiring some funding for HPV vaccination or education. 3 states distribute vaccine for free, and 3 states, only 3, actually have a mandate in 2019 that you have to have vaccination before you can come to school. And those states include Hawaii, Virginia, and Rhode Island, okay? And then Washington, D.C., because we count Washington, D.C., which is fine. So this is that contrast. And this is despite doing the math. We've now got, 2006 to 2024, we have almost 18 years of data now to actually show, as I will demonstrate, the important benefit of this vaccine. And we clearly failed, right? With all of that data in hand, all of our high hopes about the safety of this vaccine, we got it wrong, right? Like there was something fundamentally wrong about the message that we tried to sell or tried to explain to America about why this vaccine was going to help their kids, right? Like think about that. And so let me spend a little bit of time talking to you about what perhaps we got wrong. So first of all, could it be that people don't want to vaccinate their children? No, that's clearly not the answer, right? Because what I show you here in the very top, the solid line and the hatched line, this is looking at between 2006 and 2019, similar time point, right? What are the rates of vaccination for things like meningococcus and Tdap? And this is again in 13 to 17-year-olds, the exact same population. The rates are pretty amazing, right? I mean, we're looking at almost 100% vaccination. When you look all in the United States of America, and this is depicted here by the greater than 1, the kind of solid bar followed by the hatch. We are all in the United States of America, getting around 60-ish% for folks who've had 1 HPV vaccine. When you look at the number that have completed their series, that's the sort of dotted-ish line, we hover around 45%, okay? So clearly, people are getting their kids vaccinated if they think there's going to be a benefit. They're getting it done in the same exact age group, all right? So when we delve a little bit deeper, and this becomes very important to places like my program and places like your program, there are some disparities in vaccination that we can't ignore as we pause and reflect on how can we do better. So there are discrepancies when it comes to poverty status, rural status, and when it comes to sex, right, or gender of the kids. And this is continuing to sort of be unpacked, but these are themes that we see again and again. And I share with you the data that one of my residents, we're currently looking at a research project on this in our region. And rural areas, you can see with HPV vaccination, this takes us through 2020, some data from the CDC, continues to lag behind in every single time point that's looked, that's been examined, and mostly rural areas, we just have a harder time persuading people or getting our youngsters vaccinated. And there's something really important about the role we play in that as healthcare providers, but we have to recognize that's where we start, a little bit behind. So what are some of the obstacles then? If parents are willing to vaccinate their little ones, their kids, what's wrong or different about the HPV vaccine? So there have been ample studies of focus groups with parents that have looked at, so what's the difference? How do we learn from this? This is some data. And these kind of 5 pillars of responses really emerge as the common themes for barriers, right? My kid isn't sexually active. Well, we know that's not true, but my kid isn't sexually active. We don't need that, right? We don't need that yet. It wasn't recommended by my pediatrician. And this is the one that I think is really shameful, that we don't partner more actively with our pediatrics. And I have to say, where I practice now, my family practice and medicine colleagues, because they are the ones on the front lines of this, right? They're on the pointy end of having these conversations about vaccination every day. Me, not so much, right? As a G1 oncologist, the cows have sort of left the barn by the time the patient comes to see me, although I use this as an opportunity to stare down the rest of the family members and try to engage them in a conversation. Do you have any nieces or nephews? Do you have any grandchildren? Please, let's make sure that we talk to them about the vaccine, I say. But these are really the folks that have to be armed and comfortable with this data, I think, so that they can really make an impact on moving that needle with HPV vaccination. Safety concerns, it's not needed or necessary. And what's really clear is that a strong recommendation from the healthcare provider, I really should amend that, not MD, the healthcare provider, that's what really carries so much weight with these parents. So this is some more recent data that was published looking at about 39,000 teens who were not vaccinated for HPV. It queried their caretaker or the person who brought them into clinic. Why is it that you're not getting vaccinated? And it compared 2 points in time, 2015 to 2018. And what you can see is that the parental concern about the safety of the vaccine, again, this is prior to COVID, okay? It was parental concern that the vaccine may not be safe, that actually emerged as twice as common a reason that was cited by these parents, okay? And during this exact same point in time, I have to tell you, there was no uptick in safety adverse events that were associated with the vaccine. There was no actual more problems that were reported to a very robust vaccine adverse event reporting system, VAERS, a watchdog organization that keeps track and publishes on an open forum sort of the adverse effects associated with the vaccine. And you can see what this slide depicts, again, of those 5 reasons that parents chose not to, or caretakers chose not to vaccinate their children. You can see the leader, not needed or not necessary. Again, no, my child's not having intercourse. No. Come back later. Don't need to talk about that. Thank you very much. But what you can see is that the safety concerns emerged in 2018 as the number 2 reason, okay? So clearly a place for us to reinforce a safe vaccine and minimal side effects. But let's actually call it what it is, right? Because I think this was where we failed. Because we said, this is a cancer vaccine. This vaccine prevents cancer. Parents heard, you're giving my kid a vaccine that protects them from sexually transmitted diseases. That means my kid's going to have more sex. That's what they heard, okay? And I don't know what to share with you. How do we learn from this? But there was study after study that showed this was an inner city population of 13 to 21-year-olds consecutively recruited who had HPV vaccination. And they followed these youngsters after they were vaccinated, what happened to them with respect to their sexual activity. 71% of these 13 to 21-year-olds were sexually active at baseline. Half of them had a history of HPV or sexually transmitted infection. Half of them had used condoms. And what happened over that 30 months in time is that the rate of sexually transmitted infection in this population remained stable, okay? We found that girls, when they were surveyed, actually perceived they had a greater risk of sexually transmitted diseases other than HPV, and they all believed that they needed to actually practice safer sex and use more condoms. So we did not see in this inner city population that there was any sort of increase in sexual behavior. In fact, if anything, the girls who got vaccinated took more ownership of safe sex and practices. This is then amplified in a study from British Columbia. British Columbia, a vaccine program rolled out in 2008. And in comparing time periods between 2003, 2008, and 2013, what did they find? They found, and I should also tell you, about 62% at the time point of 2008 and 2013, with an in-school vaccination program in British Columbia, about 62% of the population of girls were vaccinated. And what did they see in those populations over this period of time? They found that after the advent of vaccination, you had a statistically significant reduction in the number of teens who were engaging in any kind of sexual intercourse. You can see the trend in time. Those are statistically significant numbers highlighted in red. Fewer youngsters engaged in sexual intercourse, vaginal penetrative intercourse, before the age of 14, after the widespread dissemination of vaccination. More of them used condoms with relative odds ratios greater than 1. And then finally, you can see a reduction in teen pregnancy, right, which is awesome, as a result of widespread HPV vaccination. So really, I think this is where we failed. We were saying one thing and parents were hearing something else. And I think we have to own that as we move forward. So let me then briefly move in my remaining minutes here to where's the beef, okay? And the results are clear. We have results from mathematical modeling that suggested if 80% of teens were vaccinated, we would prevent 50,000 girls from a diagnosis of an HPV-related cancer. This is what the Markov model showed us when the vaccine first came out. We then looked to some of our sister nations around the world. I like to talk about Australia because I am actually Australian. I was born there. And my family, my cousins all tell me about when I asked them about this data, they said, oh, it was very simple. What we did is they vaccinated our kids at school. They had little clinics at school. Boys, girls, everybody was welcome. And that was how Australia was one of the first countries to really disseminate such an incredibly successful vaccine program. In 2007, the first country to adopt national publicly funded vaccines in schools. And you can see 79% of girls are vaccinated, 73% of boys are vaccinated. And what did they see as a result of this vaccination program? What you can see in the youngsters who were vaccinated, depicted in that aqua solid line, is you see a reduction in the number of genital warts that are diagnosed between 2004 and 2011. And we understand, by virtue of the natural history of HPV, it starts with reducing genital warts, right? Because that's one of the most common things that HPV causes. Rwanda, an amazing effort in Rwanda to roll out a national vaccine program in which they had almost 95% of the country, of eligible individuals, of girls, were vaccinated in Rwanda with a nationwide program, which is then expanded to other nations. And we are still awaiting sort of some of the exciting data from this effort, but it shows what a country can do when it actually embraces the science and data to protect its youth, right? So pretty awesome. And I'm going to skip over to this slide. When we then look at the United States, moving from venereal warts to now cervical dysplasia, we see the same reduction. Again, the blue, dark royal blue bar and the light blue bar, what do we see? We see that in vaccinated individuals between 2008 and 2016, between 18 to 19 and 20 to 24, you see a statistically significant reduction in the number of people, women, diagnosed with CIN2 or greater, reflecting that even with our 50-ish, 48% vaccination rates in the United States of America at this point in time, we start to see a reduction in cervical dysplasia, cervical precancer lesions. It works. And we now see, and sort of aggregate data would suggest that HPV 16 and 18 infection When we look at the high income countries where there was access to the HPV vaccine, we see a reduction of about 66% in HPV infection in 20 to 24-year-olds and 86% in 13 to 19-year-olds, with a reduction of CIN2, as I've said, a reduction of about 50%, even with us hitting only about 50% of the population, right? And now we have data to suggest, going back to some mathematical modeling, what would this look like in the world with HPV vaccination if it were more readily available, and we were able to combine it with some more regular type of screening for cervical cancer. It is posited that there would be an 89% reduction in cervical cancer diagnoses in 78 countries. If we can see, as you see here, the status quo, which is depicted on the top, versus vaccination in that lime green bar, versus combine that with a one-time screen for cervical cancer, which is depicted in that blue line, versus 2 lifetime screens, again, which is really all that some countries can manage to do realistically to take care of their population. But we could quite literally eradicate cervical cancer. That is within our reach. And now 2 slides to show you the impact of cervical cancer reduction, because we're here now, right? We've had enough time since the vaccine to actually pose the million-dollar question. Do we see less cervical cancer? And the answer is a resounding yes, we do see less cervical cancer. In the US, which you can see over time, squamous cell carcinoma that I've written there for you, depicted by the predicted incidence with that hatched line. And you can then see the squamous cell cancer incidence observed with the little pyramids, the little triangles. And you see there's a 22% reduction per year of squamous cell carcinoma in the United States of America, even with our somewhat disappointing rates of about 50% HPV vaccination. And the same is seen when we look at adenocarcinoma. This is depicted for you in that sort of, again, the gray hatched line, adenocarcinoma, what was the predicted? And when you look at the actual boxes, the gray boxes, you see about a 9.4% reduction in adenocarcinoma of the cervix diagnoses as well over time, looking up to 2017. A large study from Sweden that was published in the New England Journal reinforces some of the points that we talked about earlier with our understanding of HPV vaccination and vaccinating early. And what they saw in this study of 1.6 million girls and women between the ages of 10 and 30 that were vaccinated in Sweden, again, a national policy to introduce HPV vaccination, is an 88% reduction in cervical cancer cases amongst youngsters that were vaccinated at less than 17 years of age. Still a reduction, but not the same magnitude in individuals who were vaccinated between the ages of 17 and 30. So we can really stand on incredibly firm ground now and say, it's not just mathematical modeling, it's not just HPV infection causing warts, it's actually delivering on what it promised. This vaccine works, it reduces cancer. So what have we learned? Again, you guys lived through this. We continue to live through this where I am currently. And I think it's time for us to pause and reflect. And one of my new favorite expressions as a chair, load the boat. We load the boat with friends and allies, okay? So turns out we can now, I won't say profit from because that's a bit macabre, but we can certainly reflect upon, there are other people that we can clearly partner with when it comes to moving the message. And the message is HPV is bad. It causes a lot of cancers. And oh, by the way, oropharyngeal cancer is absolutely on the rise. And HPV-associated oropharyngeal cancer has now eclipsed smoking-related oropharyngeal cancer, right? So this is what we see now. This is stuff I just pulled wicked easy off the internet, right? We see vaccination adverts with boys. Cool, right? We see pediatricians' offices. This is from pediatricians' offices. What do pediatricians need to know? And dentists, there's a friend, right? Let's work with dentists to actually move the message about HPV vaccination. And what we see is that the preliminary data would suggest in vaccinated individuals, there is an 88% reduction in HPV-related infections in boys and girls that were vaccinated, okay? So I would submit to you, how do we move this? I've already sort of outlined all of these things. We look at the data, we become well-versed in the data, we recognize where we failed when it comes to the message of effective HPV vaccination. And really with the foundation of data that we have now, we widen our circle, we load our boat. And I will share with you, this is my current research project with one of my amazing residents who actually has done a pediatric, completed her pediatrics residency and then decided she really wanted to be on our team. And we're really interested in the question of, in our region, how does COVID vaccination impact HPV vaccination? Now, the data I'm sharing with you here is the exact opposite. And it shows, not surprisingly, like vaccine behavior is a thing now. We study and we report this. So not surprisingly, it turns out that adolescents who initiated the HPV vaccination had a 4-fold higher statistical probability of getting COVID vaccination. And that speaks to their parents, right? This is the same parental behavior that we saw that worked against us with HPV vaccination. But clearly there's something here to own and try to move forward. So I will leave you with the sort of final exciting, why should we vaccinate? There is some emerging data to suggest that for an individual who is being treated for HPV-related cervical dysplasia, that individual, if she receives an HPV vaccination shortly after her local treatment for her cervical dysplasia, she will have a reduced risk of HPV-related recurrence. Now, when this was first presented to us at SGO some years ago, there was like, we're not a terribly passionate, fiery group, but this was really a very exciting talk. And people wondered, what's the mechanism of that? That can't be possible. We've been told the HPV vaccine is not therapeutic. It is preventative. That's the message that we all sort of embraced. But the mechanism that the authors have postulated may have something to do with the vaccine, perhaps being more immunogenic than natural infection. And we know that based on our understanding of the antibody that's generated. Remember from that data I showed you, much more robust antibody response to vaccination. And maybe that augments the effect of the local surgical treatment to prevent recurrence. And then we also understand the biology, remember, of you can get reinfected with a different HPV subtype, and vaccination may in fact protect you from reinfection with those other viral subtypes. So when all is said and done, there is a prospective trial called the NOVEL trial. This is, I think, I cannot pronounce this individual's name, Kyrgio is the lead author. We are not putting patients on this trial. I just discovered this in the course of preparing for this lecture. But this will be a prospective randomized trial to finally try to definitively answer the question, is there a reduction in recurrence, and what might be some of the actual biological mechanisms that are proposed to drive that? But really exciting stuff. And another reason for us to add when loading our boat, maybe there is actually some therapeutic impact. So I will conclude there. I really thank you for your attention and welcome any questions from you all.
Stay here.
Okay, I'll stay right here.
Yeah.
I was looking at the time and stressing out.
Thank you so much. Don't be stressed about the time. We've got a little extra in our program. And we stole 10 minutes from you, and look, you delivered 8 minutes back. So I think probably we have time for, 3 to 4 or 5 minutes of questions. And then I'll turn the program over to the resident research team.
Please, yes.
That was a great talk. I just talking. Okay, great.
Talking to the cube. I like that.
More of a comment. So I think that there's a lot of data, and they've done a lot of research on what we can say to patients that can most likely make parents uptake this vaccine. And for patients and parents, the line is, I highly recommend this cancer preventing vaccine. And then the other thing that we have to be really careful of is sometimes your staff sabotages you. So making sure that you educate your medical assistant. So when they're rooming the patient, they're an advocate for the vaccine as well, and not giving them false information.
Thank you. Yeah.
Thank you so much. Pregnancy and the postpartum period obviously presents like a perfect duration of time to capture someone of reproductive age who's sexually active, to get them their doses. And I know this is an inactive vaccine. The biologic plausibility is that it would be safe. It's just not approved or studied in pregnancy. So where are efforts to establish the safety for Gardasil in pregnancy, or are there any?
Oh, I love that question. And here's where I think, gosh, didn't we really, not to cast aspersions on anyone who was involved in the Gardasil vaccination in pregnancy, if you're sitting in the room, but God, we failed. Didn't we fail with that? What I saw and heard from my colleagues in population health and epidemiology is, why didn't we include pregnant women in those trials from the outset? If we didn't include those women in those trials, and you can fill in the blank vaccine would be my response to you. We have to learn. I'm now getting on my soapbox, okay? As an IRB chair for 15 years, why do we treat pregnancy like a disease? Why do we cordon off pregnant women as some special, strange species that somehow, oh, no, we can't even think about anything preventative for those people? We do ourselves such a disservice in science. And the sad response to your question is, sure, that makes all the sense in the world. But you know, an educated patient is going to say, where's the data? And the only data that we can actually gather at this point is from individuals who happen to be pregnant, who were followed, right? But as long as I'm really getting totally, but as long as we exclude women, pregnant individuals from trials for otherwise life-saving interventions and things, we will never be able to actually have the data to present to those individuals. And we simply have to change our thinking. We just have to be more inclusive of that population, because you're absolutely right. And we know that pregnancy, we're trying to write a paper now, pregnancy is a wonderful time in our opioid addicted pregnant individuals, a wonderful time to make sure that they're screened for cervical cancer. It's, you guys know it's a population that has higher rates of cervical cancer and dysplasia. There's so many barriers to care for this population. And we just forget that pregnancy is a wonderful window of opportunity to get those folks up to date and on board with care. So yes, thank you for that point.